So today we're going to pick up on the neurotransmitters, but before we do that, what I'm going to do is I'm going to show you a little film on neurotransmission. It's a very fast little film, so we're going to watch it twice, okay? And this is available to you online, so I'm going to show you where it is. If you go to Module 2, and you go down to the readings and resources, the very first item says neurotransmission, see for yourself assignment. And that see for yourself assignment always means there's something to read or watch or something like that. And so you'll see there this little video. So like I said, it goes very fast. So we will watch it twice. But at this point, the video should be a review for you. I'm going to move the camera up closer, even though they'll be able, everybody can access this on the module. Watch your tote there. Thank you, dear. You're good. That's my chest really close up. Okay. All right, so I'm gonna put this on, and we're gonna watch it a second time, like I said, because it's so large and so fast.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss synaptic transmission. Most communication between neurons occurs at a specialized structure called a synapse. A synapse is an area where two neurons come close enough to one another that they are able to pass chemical signals from one cell to another. The neurons are not actually connected, but are separated by a microscopically small space called the synaptic cleft. The cleft is less than 40 nanometers wide. By comparison, a human hair is about 75,000 nanometers wide. The neuron where the signal is initiated is called the presynaptic neuron, while the neuron that receives the signal is called the postsynaptic neuron. In the presynaptic neuron, there are chemical signals called neurotransmitters that are packaged into small sacs called vesicles. Each vesicle can contain thousands of neurotransmitter molecules. When the presynaptic neuron is excited by an electrical signal called an action potential, this causes the vesicles to fuse with the presynaptic membrane and release their contents into the synaptic cleft. Once they are in the synaptic cleft, neurotransmitters interact with receptors on the postsynaptic membrane. They bind to these receptors and can cause an action to occur in the postsynaptic cell as a result. This action may involve increasing the likelihood that the postsynaptic cell will become activated and fire an action potential, or decreasing it. Eventually, the neurotransmitter molecules must be cleared from the synaptic cleft. Some of them will simply drift away in a process called diffusion. In some cases, the neurotransmitter is taken back up into the presynaptic neuron in a process called reuptake. Once back inside the presynaptic neuron, the neurotransmitter can be recycled and reused. In other cases, enzymes break down the neurotransmitter within the synaptic cleft. Then the component parts of the neurotransmitter can be sent back into the presynaptic neuron to make more neurotransmitter. Welcome to 2-Minute Neuroscience, where I...
Okay, so did that all sound familiar to you?
Yeah.
Okay, good. So that's exactly what we went over, right? And the presynaptic membrane, we didn't talk about it that way. That's what part of the sending neuron? The presynaptic, like before the synapse, what part of the neuron is that? No.
Terminal.
The axon terminal is before the synapse, then the space, right? Then that synaptic gap. And then what part is the postsynaptic? The dendrite of the receiving neuron, right? So it's axon terminal, space, and then dendrite. And so the presynaptic is the axon terminal, and the postsynaptic is the dendrite of the receiving neuron. So let's watch it one more time. You okay with watching it again, right? Okay. It's short, but it's fast.
I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss synaptic transmission. Most communication between neurons occurs at a specialized structure called a synapse. A synapse is an area where two neurons come close enough to one another that they are able to pass chemical signals from one cell to another. The neurons are not actually connected, but are separated by a microscopically small space called the synaptic cleft. The cleft is less than 40 nanometers wide. By comparison, a human hair is about 75,000 nanometers wide. The neuron where the signal is initiated is called the presynaptic neuron, while the neuron that receives the signal is called the postsynaptic neuron. In the presynaptic neuron, there are chemical signals called neurotransmitters that are packaged into small sacs called vesicles. Each vesicle can contain thousands of neurotransmitter molecules. When the presynaptic neuron is excited by an electrical signal called an action potential, this causes the vesicles to fuse with the presynaptic membrane and release their contents into the synaptic cleft. Once they are in the synaptic cleft, neurotransmitters interact with receptors on the postsynaptic membrane. They bind to these receptors and can cause an action to occur in the postsynaptic cell as a result. This action may involve increasing the likelihood that the postsynaptic cell will become activated and fire an action potential, or decreasing it. Eventually, the neurotransmitter molecules must be cleared from the synaptic cleft. Some of them will simply drift away in a process called diffusion. In some cases, the neurotransmitter is taken back up into the presynaptic neuron in a process called reuptake. Once back inside the presynaptic neuron, the neurotransmitter can be recycled and reused. In other cases, enzymes break down the neurotransmitter within the synaptic cleft. Then the component parts of the neurotransmitter can be sent back into the presynaptic neuron to make more neurotransmitter.
Okay, any questions on that? All right, so we return back, by the way, I'm yelling because of the video, in case you're wondering. All right, so the neurotransmitter types are divided into excitatory and inhibitory, basically. So far we've been talking about excitatory neurotransmitters, which means that when that neurotransmitter fires, it gets to the dendrite of the next neuron, it encourages that next neuron to fire. But there are also neurotransmitters that are inhibitory. And what this means is that when they get to the other neuron, they influence it to not fire, okay? And then some neurotransmitters, it just depends where they land. They can land on some receptors that make it more likely for it to fire, or some that make it less likely to fire. So the main lecture today will be discussing these various neurotransmitters. Now there are hundreds of neurotransmitters, and some neurotransmitters like serotonin have many different types. But we're going to talk about these because they are really well known for what they do that affects people psychologically, and they've been well researched. So the first of these is called acetylcholine, and it's abbreviated ACH. So a lot of people, if you can't say acetylcholine, you can call it ACH. So acetylcholine contributes to movement and learning and memory processes and REM sleep. By the way, for the sake of the video, I don't know what number, she didn't number she didn't number her slides. Okay, so anyway, so it's REM sleep is rapid eye movement sleep. Rapid eye movement sleep is when we dream, and it occurs in stage 4 sleep. Now we used to think that when we had rapid eye movement, what we were doing was watching what was happening in our dreams. And we now think that that's not the case. We now think that what is actually happening is that as we think about things happening in our dreams, we are moving information from the right to the left side of the brain and going through our daily struggles and moving things from the right to the left side. So the right side of the brain, as you'll learn next time, is very emotional, whereas the left side is more rational. And what we're doing supposedly during rapid eye movement sleep is taking those emotional things and moving them to a more rational side so that they are not as upsetting to us and so forth, or we're making more sense of them. So we now have a certain type of therapy that's based on this theory. It's called EMDR, which stands for eye movement desensitization and retraining. And it's particularly useful for people who have post-traumatic stress disorder, or PTSD, people who've had any kind of trauma. And what we do is we do regular therapy, and then when we get to a point where the person is thinking about a traumatic moment, we have them follow our hands with their eyes. and we move the hand back and forth. And this happens for a few minutes, maybe one or two, and then after doing that, a lot of times people will immediately feel better. Sometimes not immediately, but a lot of times it is immediate, where the person feels like they've transferred this emotional trauma to a more rational side, and they don't feel the serious emotional effect. So in cases where there's excesses of acetylcholine, you see things like muscle paralysis, convulsions, and a person can die. But our interest is in deficits of acetylcholine, because acetylcholine is related to Alzheimer's disease. Now, most of you have probably heard of Alzheimer's. Alzheimer's is what we call a degenerative dementia. It's degenerative or progressive, which means it continuously gets worse, goes downhill, and never gets better. And Alzheimer's is genetic. Now, that doesn't mean that you won't get it if it doesn't run in your family. It just means that it does tend to run in families. It also is fatal. We don't have a cure. So in Alzheimer's disease, the symptoms are of dementia. Dementia is a situation where a person loses their intellect and their personality. Now, the dementia concept is not one that is unique to Alzheimer's. In other words, there are many kinds of dementia, and Alzheimer's is one type with particular symptoms that we tend to see, and a specific etiology or cause, as well as a prognosis that is very negative. So when we do autopsies on people with Alzheimer's, this is still the only way to get a definitive diagnosis. They can do some blood tests, and they certainly look at your symptoms to see if you're likely to have Alzheimer's. But to have the definitive diagnosis, they still have to do an autopsy. And when they do that, they find a few things that are very common in Alzheimer's, or that basically define Alzheimer's. Some tangles in the brain where the cells are all just messed up and tangled up. Some, you can read about that in your book. You can also read about aluminum. There's an aluminum plaque, a film or covering on the brain that has much more aluminum than we would expect. And then there's these areas of the brain that are particularly important to the use of acetylcholine. And those brain areas have atrophy, which is a big word for they've shriveled up and died, okay? So we know that the person has not been having enough acetylcholine. Yes?
Couldn't the atrophy and the aluminum both show up on imaging?
The aluminum does not. The atrophy does. Yeah.
So we could diagnose this before.
Well, the atrophy can be seen in other things too.
Okay.
But we can diagnose it. We definitely can diagnose Alzheimer's pretty easily. But it's not a definitive. It was definitely Alzheimer's and not some other dementia until we do an autopsy.
Okay.
But in many cases, it's like it's like 95% chance it was, because it just has all the symptoms that are unique to Alzheimer's. Okay, so we do have medications that try to slow down the progression of Alzheimer's, but none of them are a cure, so it is fatal. The person starts to lose their intellect, which is often, you hear of memory loss. The memory loss is not like, I forgot why I came in the room, or I don't know where I put my keys. It's very severe and very unusual to most people. Like, I don't know how to get home from a place I go to all the time, like school, work, or the grocery store, or something like that. Now, most people who get Alzheimer's are older. If you get it in your 50s, you're getting it young. If you get it in your 60s, you're still getting it pretty young. So by the time people are very old, it's much more common. And then part of losing your intellect also means that you make poor decisions, and you just can't do the things that you could do before, like balance your checkbook and stuff like that. And then losing your personality. A lot of that means that you become kind of childlike, and you lose control over impulses that you might have. So you might hit someone, or you might curse at them, or cry, or be very emotional. Just things that you wouldn't do as an adult or hadn't done for most of your adult life. Any questions about Alzheimer's? Okay, so over time you lose your reflexes to some extent, so that one of the last ones you'll lose is the reflex to swallow, and so you'll lose that, and you're pretty much gone after that, and then you'll lose your actual respiration. Okay, so the next thing we're going to talk about is a excitatory neurotransmitter called dopamine. And dopamine is used to control voluntary movement. It's also important to learning, attention, and thought and emotion. What's missing on this slide is the importance of dopamine in the experience of pleasure. So what happens is that our ability to experience pleasure, really pleasurable things, comes from our having enough dopamine. And we see a deficit of dopamine in Parkinson's and an excess in schizophrenia. So let's start with the deficit in Parkinson's. Excuse me. Like Alzheimer's, Parkinson's is a physical illness. And what happens here is that you don't have enough dopamine, and you start seeing tremors and involuntary jerky movements, and then eventually that leads to muscle stiffness and an inability to move. And it also is, you show no emotion on your face because all those muscles are not under your control anymore, and you can't speak because you don't control those muscles. So when one of the ways that we often start off by treating Parkinson's is by giving something called L-DOPA. L-DOPA is a precursor to dopamine, meaning it's like an ingredient, but not quite. Like, for example, if I'm making cookie dough, I apologize. If I'm making cookies, at some point before I have cookies, I have cookie dough. So cookie dough is a precursor to cookies. It's something I can change into cookies, right? And that's what L-DOPA is. So we give people L-DOPA, and initially it works, and they gain control over their shakes and their in their rigidity and so forth. And then it stops working. So we need to give more and more. And once we give enough, the person will start having symptoms of schizophrenia. So then we have to stop using L-DOPA. So there are many different medicines that are used, and there are actual cocktails. In other words, meaning trial and error. We try to figure out what combination of how much of each of these medicines is right for you and is going to work best for you. And it will give you a temporary relief of symptoms, enough for you to get around. But like, for example, Michael J. Fox, you know him, right?
Yeah.
The actor. So he has this, right? Muhammad Ali had it, right? So, Michael J. Fox talks about how, like, if he wants to be able to move tonight, he's got to go kind of without moving in the morning, so he can take this medicine later, and it will only give him a certain number of hours of relief. So he's got to kind of plan his day around when can he be inactive and when can he be active. There are also some surgeries that can be attempted for Parkinson's, and I believe that we are going to find a cure probably for Parkinson's in your lifetime. Unfortunately, I've been saying that for the 28 years I've been teaching. So of course, as you know, the pharmaceutical companies, it's not in their best interest to find a cure.
Right.
But I think that we might get there. So Parkinson's runs in families. like I said, it doesn't mean that you can't get it if you don't have a family member with it. But if you have a family member with it, you're more likely to get it, and if you do, you're more likely to get it a little earlier than most people. And often people don't get this until their 60s or 70s. But if you're getting it early, Michael J. Fox got it in his 20s, I think,
Late 20s, I think.
ridiculously early. Ridiculously early. I've never heard of a case like that. But anyway, he was 27,
Yeah,
You said? 28, something like that. That's unheard of. So,
He was in the Back to the Future movies, right?
what?
Michael J. Fox, was that Back to the Future?
Yeah, Michael J. Fox was the actor in
So he
Back to
had
the
it
Future.
During film?
Oh, yes, he did have it during there. And if you ever seen some of his comedy shows, what do you call them, sitcoms? Yeah. He does like this a lot, and he puts his hands in his pocket a lot, and that's all how he kind of controls the movement.
Wow.
So Parkinson's is not curable, and it's also not in and of itself fatal. So Parkinson's doesn't have to kill you, but oftentimes it can lead to things that will shorten your life. Like you're more likely to get pneumonia. So older people often get pneumonia from not moving around enough, and if you have Parkinson's, it makes it more likely for that to happen.
Does Parkinson's not affect the heart?
It does not affect the heart,
Okay.
not to my knowledge. I'm not a doctor, so not that good, so I don't know. Okay, so let's talk about something I do know about, schizophrenia. Schizophrenia is a mental illness, and we used to think of it as a thought disorder. And now we realize that it's way more than a thought disorder. It affects people's thoughts, their emotions, their language, their behavior. It affects their, so many things. What, did I leave out?
No, I was just saying their moods or.
Yeah, moods, everything. Okay, so in schizophrenia, we have what's called a psychotic disorder. So you can be psychotic for other reasons, but the most common type of psychosis is from schizophrenia. And schizophrenia is genetic, so it runs in families, but you definitely don't have to have it in your family to get it, okay? It's often diagnosed in the early 20s, and then we go back and we look at your teen years and we go, oh yeah, we see some signs now. Now we realize what that behavior was. So the hallmark symptoms of schizophrenia are hallucinations and delusions. A hallucination is a false perception, something you hear, see, smell, taste, or feel that isn't really there. And the most common, by far, type of hallucination is hearing voices. The voices are usually very negative. They taunt you, they tell you negative things. They may have you hurt yourself and so forth. And they also tend to be very paranoid. So the voices convince you that people are after you, that the government is contacting you through your feelings, that aliens are reading your mind, that all the billboards are secret messages about you, stuff like that. So crazy kind of, very illogical type of thoughts, okay? Now, the other, I was gonna say something about that. Oh, so how many of you have seen A Beautiful Mind, that movie? Okay, so I'll recommend that movie, A Beautiful Mind. It's a story of a man with schizophrenia, and it's a true story of Dr. John Nash, who was a mathematician who's very famous, and he had schizophrenia. And in the movie, they portray it as if his hallucinations are visual, just to make it easier for the movie watcher to understand. But in reality, his hallucinations were auditory, which is what's more common, okay? So the hallmark symptoms are hallucinations and delusions. Now, delusions are false beliefs. So all the things I said, aliens are contacting me through my feelings, all the billboards are about me, the government has a secret plan, I work for the government, secret, this or that, whatever, okay? So all kinds of odd thoughts that are oftentimes paranoid in nature, but can also be grandeur. I'm special and things like that. And we'll talk more about that in Unit 5. Now, what's happening in schizophrenia is that we think that the hypothesis is that there's too many receptor sites for dopamine. So if there are too many receptor sites, then all of these little dopamine molecules are going to find a place to bind, which means that the next neuron, this is the axon terminal, right, releasing neurotransmitter molecules into the synaptic gap or cleft, and this, of course, is the dendrite of the receiving neuron. So all of these molecules are going to find a receptor site and bind with that receptor site, meaning this receiving neuron is going to fire even when it shouldn't, right? Because it's got so much dopamine running around the brain. So in the 1950s, we came up with some medicines to help with schizophrenia, and those medicines are dopamine receptor site blockers. So they're called the antipsychotics, and they come in and they block these receptor sites. So they make them unavailable. They sit there and make them unavailable, but remember that this neuron is not thinking, oh, there's dopamine, right? It's not imitating it, it's just blocking it, okay? So that's how the antipsychotics work. Interestingly, when you take an antipsychotic, within an hour, we have really reduced the amount of dopamine that you have floating around. However, it often takes 2 to 3 weeks to see a complete change of symptoms. So the maximum improvement that you're going to see in the person won't be seen for weeks, even though the change in dopamine levels is immediate. So no cure for schizophrenia. I'm trying to remember what I left off. Any questions? No cure, does run in families, is not fatal. Yes?
This might be working my head a little bit, but what are the differences between schizophrenia and bipolar?
You're way ahead. So we're going to mention bipolar today. They are not the same thing.
Right.
But in Unit 5, we're going to go through specifically and make sure you understand the differences. Because they're subtle sometimes.
Yeah.
Okay.
I have a question on this one.
They're often misdiagnosed. So, like one is the other. Yes?
When it blocks those coming to the, here, where does it go when the medication blocks it?
Okay, so
completely
this
washed out?
medication,
Yeah.
this antipsychotic is going to come in and block
Block
these
those, yes.
receptor sites.
Yes.
When they're blocked, that means that the actual dopamine molecules will not be able to bind to that receptor site. If they can't bind, then this one will stop firing because it's not going to get enough dopamine to meet its threshold and have an action potential.
Okay, so they're
So-
gonna die there.
It will not
They
fire.
don't fire.
Yeah, because of the
Right.
receptor sites are tied up.
Okay.
Anything else? Okay, so the next thing we're going to talk about is these two neurotransmitters that often work together, serotonin and norepinephrine. Serotonin plays a role in regulating mood, sleep, impulsivity, aggression, and appetite. And norepinephrine has similar roles in eating, sleep, and mood. Okay? Now, just thought about something else that somebody was asking me. Okay, so in depression, let's talk about the symptoms first. Depression is a mental illness where a person's mood is usually pretty low, but they can also have not just be in sad, they can also be agitated or even have some anxiety. And they do not have the ability to experience pleasure and hedonia. They also don't seem to be interested in things that used to cause them pleasure, so they lose interest in things. They usually will have some sort of changes in their sleep and appetite. For some people, they might sleep too much or eat too much. Other people might not be able to sleep and have lost their appetite or something like that. So it can go either way. And in depression, people have trouble making decisions. They have very poor self-esteem. They frequently think of suicide or death. And they basically have a very negative foresight. The future they think is negative. The present is negative. They don't feel like things will get better. They're hopeless and helpless is what we call that. And what we find is that when people have depression, we usually see low levels of both serotonin and norepinephrine. So serotonin is abbreviated 5-HTP. 5-HTP. Sorry, forget the P. I was thinking about something else. 5-HT. The reason I'm telling you is because you might go to a store and find 5-HTP, okay? 5-HTP means it's a precursor, that's what the P stands for, to serotonin. 5-HT is serotonin. 5-HTP is something you might see at a health food store where they're saying you could take this 5-HTP and it should allow you to make more serotonin. You want to be careful. You don't want too little serotonin, but you also don't want too much serotonin, okay? So when serotonin is low and norepinephrine is also low, we tend to see depression. So the medicines that we used to have to treat depression, what they did is they oftentimes would go in, for example, and block those enzymes in the synaptic gap. And most of the medicines, all the medicines that we had at one point, would do that for both serotonin and norepinephrine. However, if the norepinephrine went up too high, people are going to have some negative side effects. When norepinephrine is too high, you can have paranoia and low appetite and agitation and trouble sleeping. So what they did is researchers went in and said, okay, let's try to find something that only increases serotonin and leaves norepinephrine alone. Because, by the way, when you have medicines that increase both, those old medicines, you could use those to commit suicide. So if you overdose, it would kill you. So we definitely didn't want to give that to depressed people. So what we did instead is we came up with something that just increased serotonin. And what that is Prozac. That was our first one. And Prozac is a selective serotonin reuptake inhibitor. In other words, this Prozac and the medicines that are related to it, like Paxil and Zoloft and Celexa, what they do is they seek out the reuptake centers for serotonin only, and they block those. So they're leaving more serotonin out there, but they're not affecting norepinephrine. Now, some people have atypical depression, and they need to increase their norepinephrine. And for that, we have medicines as well. We can use selective norepinephrine reuptake inhibitors. You might have heard of Wellbutrin, right? That's a selective norepinephrine reuptake inhibitor.
Are those types of antidepressants?
Yeah, that's still an antidepressant. But it's also used, like Wellbutrin is also used to get you to stop smoking, for example. Okay, so let me see what else I want to say. So some people have depression, and other people have something called bipolar disorder. When you have bipolar, sometimes you have depression. And when you do, it looks like this, typically. Just like the depression that I told you about a moment ago. But other times, people with bipolar are manic. And usually it's when their serotonin is low, but then their norepinephrine is high. So serotonin is low in both cases, but in mania, norepinephrine tends to be high, whereas in depression, norepinephrine tends to be low. And people with bipolar disorder are treated with a category of medicines called mood stabilizers. And they are lithium-based typically. People with bipolar disorder usually have to stay on their medicines most of their life, or all of their lives. They may take breaks, and so forth, but for the most part, usually they have to go right back to it. The antidepressants are not something that you usually stay on for the rest of your life. Most people will be on them for about a year. 6 months is when you would first even think about possibly getting off, but for most people that's not enough. Now, I have depression. It runs in my family, which depression tends to do. Bipolar disorder runs in families even more than depression. Depression happens more often in women than in men, but bipolar is the same in men and women. So I have depression, and I've had it really since I was a teenager, but I got treated in my 30s, and I've stayed on my medicine. I'm on Celexa right now, and I have been for many, many years, which is a selective serotonin reuptake inhibitors. And I've been on a medicine since I was 32, and I'm going to be 57 next week. So basically that means that I've stayed on it forever, because when I get off, my thoughts get negative, and I start getting agitated, and I realize, I'm going downhill. Yeah.
I have 2 questions.
Okay.
So, the first one is, would you say depression is the same thing as anxiety?
Is depression the same thing as anxiety? The answer is no. Okay, it is not. Depression and anxiety are very different. Depression, symptoms are different from anxiety, but oftentimes people have both depression and anxiety. So in Unit 5, we'll look at the exact definitions of those.
Okay, and then, so you said that you've been on depressants for like a while, so would you say that's healthy or not healthy for your mind?
I know what happens if I get off,
Okay.
so it's definitely healthy. I mean, for me, because if I'm not on it, I start getting depressed. It's not good. It's not good. But I have something that we'll talk about in in Unit 5 as well. I have something more chronic called dysthymia, which means that you've chronically had depression, and it runs in my family and stuff. So.
I think you might have actually just answered my question. Sometimes you hear the term clinical depression talked about. Is that just they threw that in front of the word depression, or is that like long-term depression?
Yeah. No, clinical depression versus depression, or major depression versus depression, it's all the same.
Okay.
But you know how I might say to you, man, I'm so depressed,
Yeah.
because my team lost. Okay, when we say major or clinical depression, we're talking about the disorder.
Okay.
So that it's just to be more specific. But if we're talking about disorders and I say depression, obviously we're talking about the
clinical
disorder.
depression.
Yeah.
Okay.
Clinical or major
So
depression.
then dysthymia would be like a long-term clinical
Dysthymia
depression?
it's a chronic, milder form of depression.
Gotcha.
Okay, so yeah. So when people have bipolar, their downs are just like depression, but their ups are called mania or manic states, and they don't need to sleep. Their thoughts are racing. Often their speech is pressured. They do things that are very impulsive and not very good in the long term. They never go to the doctor and knock on the door and go, I'm manic, because they actually feel very good during the mania. That feels like a good thing to them. They feel energized and so forth, and often don't that light is killing me, and often don't realize that they're not okay. So sometimes with mania, the symptoms can even become sort of psychotic. That's why it's often misdiagnosed as schizophrenia and vice versa. So in mania, a person may do things like buy $100,000 worth of drums because they think that a famous band is going to call and ask them to be their drummer, when they barely know how to drum. So they have this crazy optimism, and they may go out and do things that they normally wouldn't do, like cheat on their spouses or spend money they don't have, or or have unprotected sex, or drink and drive and stuff like that. And so we treat that with like I said, the mood stabilizers. Any questions?
When they have mania, it's like when it causes these crazy actions, like buying things that they don't need, but when it's down, it's just, when it's not mania, is the medication the same?
So you're asking, in mania they do these things that are kind of quote unquote crazy for them,
Yeah.
and then when they're down, it
yeah,
looks just like
depressed.
the depression that I talked about before.
So that part's gonna be treated like depression, this part is different?
No,
No,
if
same.
you treat a person with mania like they have depression, they will go into a manic state usually. You need to treat them with mood stabilizers.
Stabilize.
So if you come in and you have depression and they treat you like you're depressed and you have a bad reaction, they're like, oh, wait a minute, you looks like you're bipolar.
Oh, okay.
But you have to be careful too, because like, for example, my buddy is really depressed right now because he has a lot of health problems. And so we were talking and he told me, I asked him, have you ever been on an antidepressant? And he's like, yeah, I was on an antidepressant when I was really young. But I had a reaction that was really weird, and they told me, that maybe I was bipolar. And I said, how old are you? And he said, like 20. Well, that's ridiculous, okay? Is what happens is people react differently when they're young. We used to say if you're a teenager, we have to be very careful giving you antidepressants. But in fact, now we've brought it up to age 24. And from 24 down, when we give you an antidepressant, we really have to watch you to make sure you don't have a weird reaction. Some people get manic, some people get very suicidal, which they're not supposed to do on that medicine. So we have to watch you because young people can react very differently to antidepressants.
With the bipolar, are you saying that if somebody's diagnosed in their 20s, that might not actually be what they have?
Well, okay, let me tell you something about bipolar. Bipolar is usually going to be diagnosed when we see a manic state. So if not, we're going to think you're depressed. If you're down, we're going to think you're down. Unless we're down and when we ask you about things, usually we have to ask somebody else, then they're like, yeah, they've been manic, okay?
Right.
And then you'd get the right diagnosis. But diagnoses like schizophrenia and bipolar are often first diagnosed in your early 20s.
Okay.
So it would not be unusual to get your diagnosis of that in your early 20s. Okay, before we talk about GABA, let's talk about all these medicines. First of all, you read chapter 1, I hope, because you were supposed to. And in chapter 1, you learned the difference between a psychologist and a psychiatrist, right? So a psychiatrist is a medical doctor, and their treatment of mental illness, their whole thing is, I'm going to meet with you 15 minutes and I'm going to give you some medicine. Psychologists, we're all doctors too, but we're either PhDs, which is a doctor of philosophy and psychology, or EDD, which is a doctor of educational psychology, or like me, I'm a PsyD, which means I'm an actual doctor of psychology, okay? So we specialize in testing. That's what we do that most people don't do. If you go see a counselor or a psychiatrist, they might give you a little short test on something. But if they want to really know what is your IQ, what is your personality really like, and all of the, do you have certain disorders and stuff, a psychologist is the one that usually does the testing. and psychologists also treat disorders and diagnose them. But the treatment is done through psychotherapy, right? Talking rather than medication. Now, in all of psychiatry, they have no medication that cures anything. In fact, most of medicine doesn't have medication that cures anything. Antibiotics are awesome, but really what they're doing is they're helping your body to cure something, right? So anyway, in psychiatry, they don't have any medicines to cure anything. So all the medicines I just told you about, let's go back and see what they were, okay? So we're talking about the medicines for Alzheimer's, the medicines for Parkinson's, the medicines for schizophrenia, which are called antidepressants, and the antidepressant, antipsychotics is what the schizophrenia ones are called, the antidepressants for depression, and the mood stabilizers for bipolar disorder. All of those do not cure anything, okay? So all those do is alleviate symptoms. If you have schizophrenia and bipolar, you may have to stay on those medicines your whole life. Most people with depression do not have to stay on the medicine their whole life. All of those medicines are also not addicting. There's nothing addicting about any of the medicines that I've talked about. Not psychologically and not physically. So you don't need more of the same medicine. You don't build tolerance, in other words, and so forth. Now, they all have pretty nasty little side effects. The antipsychotics and the mood stabilizers make you gain a bunch of weight. They make you extremely sleepy. You get dry mouth, diarrhea, or usually constipation, actually. And so very, very negative, yicky side effects, okay? And then the antidepressants, the newer ones have some interesting side effects. So they can cause headaches, blurry vision, muscle twitchings. They can cause diarrhea or constipation. The most common side effect that the selective serotonin reuptake inhibitors have, which are the most common type used, is that they affect your sex drive. So when you first start taking them especially, you lose your sex drive. And if you do try to have sex, you have trouble having an orgasm, for example. So this is a real problem, but the good news is that after a while, for most people, it gets better. So after a while, for most people, it's not quite as bad. Eventually you get a little bit of your sex drive back. Eventually you can have an orgasm, but it'd take you longer than if you weren't on the medicine. And you would be more interested in sex if you weren't on the medicine. So these medicines are not used and abused. They're not abused by people. People aren't like, oh yeah, I love my Prozac, I'm gonna get on my Prozac, or I love how it makes me feel. They don't make you feel high at all. They make you feel not depressed, or a little bit more stable. But the medicines we're gonna talk about now, these anti-anxiety medicines, they are definitely addicting. So GABA is a neurotransmitter that is inhibitory. So it's the only one that we've talked about so far that when it fires, it tells the next neurons to not fire. And it's important to controlling the anxiety that people may feel. So if you don't have enough GABA, you're likely to have anxiety, okay? Because GABA's presence will decrease anxiety. So what happens is that we treat the lack of GABA or anxiety, we treat it with what are called anti-anxiety medicines. They used to be called minor tranquilizers. And the medicines include Valium, Xanax, Ativan, all of your faves. Yeah?
Why is there a nerve blocker named gabapentin?
I'll talk about gabapentin in a minute. Okay. So, in those cases, those medicines are very, very addicting, meaning you need more and more to get the same effect, for example, okay? And if you get off of them, you have some negative effects, increased nervousness and stuff like that. So you need more and more, and they do less and less for you, and you need them for less and less anxiety-provoking things. So, you know, you might have just used them in a major situation, and then you start using them just to take tests, and now you're using them just to get to class, okay? So more and more you need it. So, sorry, I forgot what I was going to say. So let me answer your question, I think, next. So GABA may be related to epilepsy. And we used to have this medicine called gabapentin, and what it did is it was helping to control epileptic seizures. And now they found that gabapentin actually helps a lot with nerve pain.
Right.
And so that's what I'm on. That's what's made me walk. Yeah, the shots that I took, and mostly the gabapentin is helping me. But when you first,
Tolerance to it.
yeah,
Gabapentin.
yeah. I mean, so here's what happens with gabapentin. Okay, so first of all, when you first take it, it knocks you out. Okay, so my doctor, the nurse practitioner at my general doctor's office told me to take 3 a day, right off the top. So I would take 2, and I would pass out too hard to possibly take a third. And I mean, I'm talking, I've never been high like this. I mean, we're talking, I'm as high as a kite. So I'm sitting there, I remember I'm talking to my friend, and I'm watching TV in my man cave, and I'm like, you know what? I'm not sure if I'm wearing underpants. I can't feel my bottom of my leg. I don't even know if I'm wearing pants, okay? Better take a look. Yes, I am. Good job. Okay, high as a kite. Then I went to my pain doctor, and my pain doctor's like, whoa, whoa, whoa. You take 1 of those babies a day, 1 a day, and you have to get used to it. So my mom, who's been on it for 30 or something years, takes it 3 times a day, and she deals with it. But I take 1 a day. I had, first of all, the way I built myself up to take it 1 a day is I spent one of my weekends, you know, I always have Fridays off, so I spent a long weekend, and I took 2 a day for 3 days in a row.
Oh my gosh.
So that I could just and I was high as a kite. But basically what I was doing is trying to build it up, right? And so then on Monday, I didn't take any until I got home, and I took 1 at night. So now I take 1 at night when I go into bed, and I'm okay. But and I don't have that high and stuff like that. I mean, I don't know if I wake up in the middle of the night, if it's high as a kite, but I don't think so, because I have woken up in the middle of the night, and I don't feel high. But you have to build a tolerance for it. And then that means you need, you know, you do build a tolerance for it, but you don't up the dose to, you know, for more than 400 milligrams 3 times a day. You don't take it any more than that. If that doesn't work, you add something else.
It never had that high effect on me.
Oh my God.
It's so weird.
Did you only take 1?
So now I'm at 2 a day, but I started off at 1 a day, and it's never done that to me.
Yeah, when I take 1 a day at first, it was like,
It made me
okay.
tired at first.
right, really tired. But the 2 was like flying.
Yeah.
I was flying. So, I don't know what I was going to tell you. Anyway. Oh, okay, so the next one I want to talk about is not on here, but I want to talk about the medicines that we use to treat people with attention deficit disorder or attention deficit hyperactivity disorder, right? People who have that, they're different from the rest of us in the way they respond to amphetamines, which is what is given to them. or used to be most of the time. Now, I think they have other things too, but amphetamines is still primary treatment. So, an amphetamine makes you high, right? It cuts your appetite, and it makes you very, very awake, and it makes you feel very good. And if you or I took it, and we didn't need it, it would make us so jittery and nervous that we couldn't concentrate on shit, right? We'd be like, what? Okay, okay. But people who need it, when they take it, it actually calms them down and allows them to focus. See? Now, some people abuse it because they take it to feel high and, so forth, or they take it to not eat so they can lose weight and so forth. And so those people are jittery and stuff, and that is addictive. So you need more and more to get the same effect. And of course, if you try to get off of the amphetamines, you get super jittery and super uncomfortable, and you want to take it again. So children react differently to this than adults do, so they don't have that same reaction. By the way, ADHD continues for people, and attention to ADD and ADHD both often continue into adulthood. I want to say I read like 30% of the time, something like that. And one of the main symptoms of an adult having this is they can't hold a job. They seem to, always be changing jobs. So that's a thing. Okay? Any questions? Yeah.
So would you say they're the same?
Hey, what?
ADHD and ADD?
No, they're not. Attention deficit disorder means that you have trouble paying attention. And attention deficit hyperactivity disorder means you have trouble paying attention and you're also hyper.
Okay.
Okay? Yeah. Now, all these things have different names because they're not the same thing.
Okay.
Yeah.
In the early 2000s, when we kind of saw a huge increase in children being treated with ADD and ADHD, it was often said that children would grow out of this once they went through puberty. Not always, but that it was common. Is that no longer the
No, it is. It's common to grow out of it.
Okay.
It's more common to grow out of it than not.
Would you say it could pass on to like your kids?
Yes, there's a genetic component.
Okay.
My wife and her children, for example, 2 of her children, are so ADD. My wife is like, squirrel, For her, it's like, ooh, shiny, and ooh, shiny here. She cannot stay on the same train of thought. And the kids are terrible that way, horrible. And they have the hyperactivity too, really bad.
Is diet a factor as well?
People say diet is a factor,
Right.
they
I
say.
wasn't sure if we had a lot of conclusive studies behind that.
I don't know. I'm not gonna pretend that I know enough about that to answer you.
Okay.
Like, does sugar make you hyper and crap? I don't know. I mean, I also think that sometimes, it may make this kid hyper and not this other one. So try it and see. If it helps, then it helps.
Would you say there's like a difference between male and female, or no?
ADD?
Yeah, and ADHD.
Okay. I would say yes, because socially we expect certain behaviors from boys and girls. So even though the symptoms are basically the same, the way they express themselves, like as hyper, may be different in girls than it is in boys. Girls might talk a lot and move around a little bit, but still stay sitting down.
Yeah.
And boys might get up and run all over the place, but it just depends on how you're socialized at home too.
Okay.
What else? Okay, let's talk about this one. Endorphins. The endorphins are chemicals that we have in our body that act like opiates. So in other words, or the opiates act like them, I should say. But endorphins basically are released when we are in a dire situation. We've pushed ourselves or we're in extreme pain. And the endorphins are released and they allow us to experience pleasure as well, and well-being, a sense of well-being. But the most important role appears to be for pain relief. So
Is that just physical pain or like mental and
physical pain only.
Huh.
So what happens is that when drugs like opium, the drugs that are in the class called opiates, opium, morphine, heroin, they go in and they pretend to be an endorphin. So they fall into those receptor sites, and the body thinks, the dendrite thinks, the receptor site thinks, I just got an endorphin. And so it gives you that feeling of well-being and the relief of pain. Any questions about that? Okay, so let's talk about then how all of these psychoactive drugs work, okay? So first, some psychoactive drugs affect the release of neurotransmitters. So for example, the drugs that are in the category of amphetamines, which are also called speed, they increase the release of dopamine, which makes you feel pleasure, and norepinephrine, which makes you edgy and paranoid. Okay? So they actually increase the release of those. Now some drugs and street drugs and medicines bind with the receptor sites and pretend to be something they're not. They pretend to be a neurotransmitter. So the opiates, like I just said, they bind with the endorphin receptors and fool the receptor site into thinking it just released endorphins. And the minor tranquilizers, the anti-anxiety medicines, like Valium, they bind with GABA receptor sites and fool the GABA receptor into thinking that GABA has been released. So the neurotransmitter will fire, the next one will fire because it thinks it got that. Some psychoactive drugs block the receptor sites to make them ineffective. So I told you that the antipsychotic drugs that are used to treat schizophrenia, they go in and they fit into the receptor site, but the receptor site is not fooled. They're not molecularly close enough for the receptor site to think, I just got dopamine. Instead, they sit in that receptor site and they bind in there, they don't bind, they block the dopamine from getting to the receptor site and binding. And then some medicines disrupt the reuptake of or clearing out process. So I told you about the selective serotonin reuptake inhibitors. What they do is they select serotonin only, and they block that reuptake center. So more of those serotonin molecules will stay in the gap and be available to hit a receptor site because it's not being recycled through the reuptake center. And the same is true of cocaine and amphetamine. Both of them slow the reuptake of dopamine and also of norepinephrine. So notice what happens if you take amphetamines. You're not only releasing more dopamine and norepinephrine, but you're also slowing the reuptake of both of those. That's why speed is very powerful. What questions do you have? Yeah,
So two questions.
okay.
Amphetamines or speed, there's that increase in like energy and almost like manic mental process because of the increase of the release of dopamine. However, we see an increase with that same level of energy and almost thought process with cocaine, even though there's the slow of the reuptake of dopamine. So why is there similar
Because
results?
both of them increase the amount of norepinephrine and dopamine.
Okay.
Okay, so if you're releasing more, it increases the dopamine and the norepinephrine. And here you're blocking the reuptake.
Okay.
So you're stopping the recycling and keeping it there in the synaptic gap. Okay?
Okay.
So both of those conditions will lead to an increase in the amount of dopamine and norepinephrine.
My other question is, we say that the brain doesn't fully develop until early adulthood, is that correct?
Yeah.
So when we see children who are taking ADD or ADHD medication, their brain is still developing. So is it possible that due to the medication, their brain might actually develop in such a way that the GABA or dopamine or serotonin receptors are affected?
It could be. I mean, I haven't heard anything specifically, any research specific to that, but it could be that it's changing their brain some. I mean, it's certainly possible. I'm sure it's been researched because we've been using those drugs a long time.
Long enough that there should be
There should
able
be
to long-term research on these things. At least the last 20 years, I guess, that they've been common enough that we should be able to have some
We
kind of
should
data.
have some longitudinal
Yeah.
data on what happens,
Mhm.
but I don't know the answer to that. Other questions? That it? Let me turn this video off.